Yes, we can start then. So first of all, thanks everybody. A few disclaimers from at the beginning. I'm a family doctor, but I haven't been in practice for about 25 years. I do academic and educational work now. So although I have some familiarity generally with this, I don't have any firsthand experience either diagnosing or treating patients with COVID-19. I have a master's degree in community health and epidemiology, although the type of epidemiology I was doing was clinical epidemiology, where I was reviewing studies about drugs and therapeutics and seeing how they apply to patients. So I don't have any really firsthand experience in the type of community epidemiology and pandemic epidemiology that our experts have that have been guiding us through this pandemic. So that's my second disclosure. The third is that things are moving very quickly. The information I'm going to present was updated last night, but I see that there's already, today, there's a new model that's come out for Ontario, so parts of my presentation are already outdated. And the final disclaimer is this one. This is not intended to give you specific medical advice, and any decisions about your healthcare should be made in consultation with a healthcare professional. So this is about 30 minutes, and it's really just to provide some background for discussion. It's not necessarily a Q&A. It's just to give people, when I proposed this to Shauna, the conversation was something like, Shauna, would it be a good idea for us to just have a discussion about COVID? Because there's a lot of bright people in the group, and it'd be nice to hear their thoughts. They come from a lot of backgrounds. And she said, yeah, that'd be nice. Why don't you prepare some background information for us? So that's how this came to be. Now, this is a bit of a cliche, but trying to pick out information for COVID-19 is a bit like trying to take a sip of water from a fire hydrant. There's just a torrent of information coming out. And so I've just tried to pick and choose a few things to sip on. And these are my sips that I'll be covering over the next little while. The coronavirus and how it affects the body, people's experience in intensive care, something about testing, and some statistics. And I look forward to hearing what sips you've been able to glean from this torrent when we had the discussion. I don't know if this is too basic or not. I apologize if it is, but it'll provide some background, and some will be a repeat of the videos that I listed to look at beforehand. Well, first of all, a bit about the virus itself. This is the bad boy on the block, and it consists of this lipid membrane here in gray that's studded with these spiky proteins, and it's these proteins that adhere to our cells and allow the virus to get into our cells. And the virus itself is not alive, so if there's virus particles on a doorknob or something, they don't reproduce. They don't multiply on the doorknob. They can only reproduce once they're inside our cells. So these knobs stick the virus onto our cells. The virus particle gets taken up into our cell. The lipid membrane breaks down and it releases this RNA inside into the cell. And this RNA sort of commandeers our own cellular machinery, which induces our cells to make more of the viral RNA, which produces more of these particles. And as they accumulate in the cell ruptures and distributes more viral particles to adjacent cells, and the infection spreads like that. Now, because this lipid membrane holds a cell together, and it's made of fatty things, it's also susceptible to soap. So when we wash our hands with soap, it disrupts this lipid membrane, and that's why it's so effective, such an effective way of getting rid of the virus. Now, in the body, the infection starts up here in the upper respiratory tract and then moves down through the trachea and the larger airways. And eventually, if you're unlucky, it gets to the periphery, which is where the alveoli are. And the alveoli are these little sacs, and this is where gas exchange takes place. So they're surrounded by capillaries. And there's a very efficient exchange of oxygen and carbon dioxide across this space here. And this space is very thin. It's only a couple of cell walls thick. And this exchange is very efficient. Now, when the virus particle invades these or infects these cells, they swell up, they produce mucus, there's a lot of inflammation here. And so this gas exchange is impaired. So the oxygen can't be transported across that membrane as easily. Also, the larger airways over here become inflamed. They narrow, they can go have some spasm, they produce mucus. And so the pipes, as it were, have become narrower. And as a result of that, it becomes more difficult to breathe. And breathing takes muscular effort. And the muscular effort can be too great for some people, especially if they're elderly or frail. And that extra muscular effort combined with the impaired oxygen transport here is what leads to the respiratory distress. And there's been some information accumulating too that the virus may have some effect on kidneys and the heart. We don't really know if it's affecting them directly or if it's just because if it's secondary to the respiratory distress. Now, if the respiratory distress becomes, most of the symptoms are, about 80% of people have mild symptoms, which clear up in a couple of weeks. About 15% have severe symptoms, which may require hospitalization in the last 3 to 6 weeks. And about 5% down here become critically ill, and half of those die, and they also take several weeks to recover. And these are the people that end up going to ICU and being put on a ventilator. And this is about as happy a picture as you can get of somebody being intubated on a ventilator. So they had this tube going down into their airways, and this is the ventilator here, and it takes over the work of the muscles to move air in and out of their lungs. Oops, sorry. Now, this is not a pleasant experience for most people. There's a tube going into your stomach. They have to suction this intubation tube. The guy's catheterized, can't move very much. It's not a pleasant experience for most people. And this is not how it would be in a COVID room, because this technician here would be in personal protective equipment. He'd be covered head to foot, and there'd be all sorts of isolation procedures around, so it wouldn't be nearly as clean and neat as is shown here. Now, going to intensive care for this treatment is not to be taken lightly. And something that's come to light recently is something called post-intensive care syndrome. And I wasn't aware of this until a few months ago when I attended a lecture by Dr. Ward Patrick, who's a specialist in Halifax. And he's a specialist in this condition. We used to think that people went to ICU, they got tidied up and carried over the hump, then they went back and they were fine. And one of the videos that I listed there was done by a person who had experienced post-intensive care syndrome. And if you haven't looked at that, I'd encourage you to do so. It's quite moving. So this syndrome affects about half of the people who go to ICU. And there's a number of manifestations. It can lead to cognitive impairment in up to almost 80% of people. This can manifest itself as short-term memory, a difficulty with concentration and slowing of mental processing. They can have symptoms of PTSD, such as depression and anxiety. They can have chronic pain in their shoulders and back and legs. And they can have weakness from being immobilized in ICU. And these symptoms can persist for months. And they're worse in people who are intubated and intubated for respiratory distress syndrome. And these are the type of patients that you expect with coronavirus infections. They're also more likely to occur in patients who have been intubated for 7 days or more. And recently on the news, there was a report by some ICU doctors here saying that their experience with the coronavirus patients was that they were requiring longer periods of intubation than they were normally expected to dealing with. So the coronavirus patients are being in intensive care for longer periods of time than is normal. So that puts them at greater risk of having this post-ICU syndrome. The syndrome also affects the family members because they see their loved one in distress like this, and it affects them as well, and they too experience symptoms of PTSD. And this may be worse with coronavirus because they can't even visit their loved one because they're in isolation. So I don't think this is something to be taken lightly. I mention it just in case either you have to go there or somebody else you know ends up going there to ICU. If you start to have these symptoms afterwards, you're not imagining it. It's a well-recognized constellation of symptoms. So now I'll talk a little bit about testing. And testing is, there's a lot of uncertainty about that. And there's 2 phases of testing. One's for the acute phase where we do these nasal swabs like this. And what we try and do is to get some virus particles, and we test for the RNA genes in the virus with a polymerase chain reaction. And when we have a laboratory test, we like to define the parameters of that test to see how accurate it is. And these are things like how many false positives you get and how many false negatives you get. So I emailed a virologist that I know in Halifax and asked him what the parameters were for this test. And he said, well, it's so new that we really don't know. We don't have good information about how accurate this test is yet. But if you look over in the bottom left here, I have read that there's a high rate of false negatives. So you can have the test, it'll say you're negative, but in fact, you do have an infection with the virus. And this may be because of poor collection techniques. You've got to get that swab up there in the nose to pick up the virus particles. Maybe because it's done too soon, there's not enough virus particles to detect. Or maybe because it's done too late, the virus particles may have left the upper respiratory tract and moved into the lungs and no longer be detected on this nasal swab. Or it may just be that some way the test is processed is not what it should be. So that's sort of the bad news about the false negatives. Some of the better news about false negatives is that I just a couple of days ago read about somebody who'd done some modeling on the usefulness of this test, assuming different rates of false negative results. And even with something like 60% of false negative results, if you followed up the people who were positive and you isolated them and you followed up their contacts and isolated them, you could still get benefit from the test, even though there's a lot of false negatives. So it does have some use. Although the policies vary in different countries, and people always say, oh, we've got to do more testing, we have to do more testing. But they don't always say what they're going to do with the tests after they get the results. And I think South Korea is a real model for this because they did tons of testing. They brought their infection under control quite quickly. But they not only tested, but they isolated the people who tested positive. They tracked down their contacts, tested them, and if they were positive, isolated them and tracked down their contacts and so on. So that's an important part of the testing, is the follow-up. So that's one type of testing. Now the other is antibodies, and you may have heard about this. And antibodies test, or they're supposed to test, whether or not you've had the infection. And there are two types of antibodies involved. There's immunoglobulin M, which are IgM, and immunoglobulin G, which are IgG. And the IgM antibodies are produced in the early stages of infection, within a few days, and they last a few weeks. The IgG antibodies come on, say, 1 to 2 weeks after the infection, and they last years or maybe even a lifetime. That's in other viral infections. The theory behind the antibody test is if we take your blood and we check for these antibodies, if you have IgM, that means that you're in the early stages of an infection. If you have IgM and IgG antibodies, that means you're a bit further along. Maybe you've had it in the past few weeks. If you have only IgG, then you've had the infection sometime in the past, maybe a few months in the past. And the hope with this is that, if you've got the IgG antibodies, that you're immune to the coronavirus, and that you can now go back out and maybe go to work and not get infected again. And there's a lot of companies now making these antibody tests. And a few weeks ago in the UK, they had ordered something like 3.5 million. They were going to make them available through Amazon so people could do them at home with a pinprick and test themselves. But just the past little while, there's been a lot of questions raised about the accuracy of these tests, how well they detect these antibodies. And also, we just don't know how long the IgG will last in the body. We don't know how long it will confer immunity and how many people will be immune to this IgG. So there's still a lot of work has to be done on the antibody test. Now, if it comes to pass, it will be a big breakthrough, but we have to do more work on it before we're ready for that. Now I'll go on to how the virus spreads, and this was in the first video link I mentioned about the mathematics. And up at the top here, we've got two types of spread. One is linear and one is exponential. Now, we're used to thinking in linear terms. So up here, things increase by a factor of, increase by 2 for every time period. So 2, 4, 6, 8, 10, and so on. And that's this green line down here. That's this type of line we get down there. And that's what we're used to thinking in terms of. However, the coronavirus spreads exponentially. So it doubles. Every time in a given time period, it will double. So it will go from 2 to 4 to 8 to 16 to 32 and so on. So that's a much different pattern than the linear trend. And part of the difficulty is that at the beginning, down here in this deceptive zone, the two lines are very similar. And it's not until you get a bit further along that the exponential line starts to diverge, and you go up a little bit and you think, oh gosh, what's happening? Where are all these events coming from? You go a bit further and say, well, I wasn't expecting that. You go a bit further and say, oh my God, what's happening? The coronavirus travels exponentially. The difficulty is that we get seduced into thinking it's going to be a linear trend. And the answer, there's a couple of things we can do to improve this situation. And I'll show this in the next couple of slides. So this shows a doubling period of 2.4 days. So in the blue line here, it shows the trajectory if the events like infections or death or whatever they are you're measuring, it doubles every 2.4 days. And then if you start to isolate people who are infected and you're 50% successful, so you isolate 50% of the people who are infected, the line comes down to here. If you isolate 90% of the people, the line comes down to here. And if you isolate 99%, the line comes down here. So Korea is probably working down around the bottom here because they were very aggressive with their tracking and isolation. So that's one way to lower this curve. Now the other way is with distancing, and that's what we're doing now. And the important thing with distancing is to do it early, or with any of these interventions, is to do them early in the process. So once again, the blue line here shows doubling every 2.4 days without any distancing. The green one, the red one is with distancing early on. The yellow one is with distancing 2 days later. And the green one is with distancing 5 days later. So you can see that just a few days delay can make a big difference into the steepness of this curve. Now, I think in Ontario, we were somewhat lucky because we were able to start our distancing down here. We started our distancing at about the same time as the people in Europe started their distancing, but they were much further along than we were. So we were able to do our distancing early on in the curve, and I think that's why we're doing better now. There was a bit of uncertainty there at first because Rob Ford wanted people to go away and have a nice time, have a good holiday, and he wanted people to have a good St. Patrick's Day at the bars. But he came around and he shut the place down quite quickly, and so I think it's one of the reasons we're doing okay. So the effect of those interventions that I mentioned is to increase the doubling time. And I don't know if you had a look at the video, but simply increasing the doubling time from 2 days to 2.5 days makes a big difference to the slope of the lines and the outcomes. And this shows the slope of the lines with doubling every 2, 3, and 4 days. Now the lines don't look that much different, but you have to look at the scale over here on the left. It's a logarithmic scale, so it goes up very quickly. So the bottom is 100, but it goes up to 500,000 at the top there. So if you look at the ends of these lines, there are about 400,000 events for doubling every 2 days. By decreasing the doubling to every 3 days, we get down to 30,000. And by doubling every 4 days, we get down to 10,000. So increasing our doubling time makes a big difference. So now I'm going to show you just some graphs of some events. And this shows the number of deaths in Italy, USA, and Canada. And this is the way graphs are commonly presented. And if you look at and we hear how bad the situation is in the US, and they're in red. So you can see that they started out below Italy, and then they crept up to become equal. Now they have more deaths in USA than Italy. But that doesn't take into account the population of the US. And the population is much greater than in Italy. And oh yeah, you can see Canada down here too, little tiny blips at the bottom in green. But if you take the population into account and express this as deaths per million population, then the US is much lower than Italy. And Canada is now starting to appear as well. So this is a much more informative way of presenting this information. I wish it was presented this way more frequently. Now this shows some deaths per million population in various countries. This was as of last night. This is mostly a lot of European countries. And I've highlighted Canada and the US in red so you can see where we stand. and we're doing okay. Now, I've also highlighted these three countries because these three countries haven't had the same aggressive distancing regulations put into effect as we have. Iceland in particular is doing okay. And Sweden thinks that it's turning the corner now, even though they have been doing some voluntary isolation. It's not to the same extent as us. They just thought it was important not to cripple the economy, to come to some sort of compromise between slowing the infection and crippling the economy. Now I'll put in some other places here. So Quebec is 103, so that's where they are, 133 deaths per million. Ontario's 38, Ottawa is 16, and BC is 15. So that'll give you some idea of the relative standing of some of these places. Just to remind you again about the effect of the increasing the doubling time, because the next slides I show are going to be showing you how doubling times have changed in some places. This is the doubling time of deaths in Canada, and each of the little blue arrows pointing down indicates a period when the number of deaths doubled. So you can see that for the first five doublings, the doubling time was 4 days. Then we went to 6 days, and then we went to 5 days. So our days are increasing, which is a good thing. I think part of this change here is because of all the deaths in long-term care facilities. So we've got a spike there that's affecting the doubling time at the end here. And again, just to give you some idea of the doubling times in different countries, here they are. So in Europe, their doubling times are much longer than ours, which is good for them, but it indicates I think they're further along in the stage of their infection than we are. So they've got more deaths, but they're further along, and their doubling times are starting to stretch out. Now this is Ottawa, doubling times of deaths in Ottawa, and you can see that, again, we were at 5 days for a long time, and we were doing really well down here. We were going 8 days, and then we got this spike. And that was from 7 deaths in a long-term care facility. If it hadn't been for those, we would have been stretched out for many more days in Ottawa. So Ottawa, I think, is doing quite well. And now I'll show you the doubling times of deaths in Ontario, BC, and Quebec. So this is BC, and they're in red. You can see how flat their curve is. They've got a long time in between their doublings, 11 days, and they've had only 3 doubling periods in the past month. This is Ontario. We've had 7 doublings, and at the end here, we're up to 6 to 7 days. So we're improving as well. Quebec, unfortunately, is not as doing as well. They've had 8 doublings within this month, and they're doubling every 4 to 5 days. And now I'll show you a couple of projections. This was, let me see, I have to put it up here. This was a projection that was published on the CBC April the 4th. And this is the projected Ontario deaths by April the 30th. So if we persist in our current intervention, they predicted we would have 1,600 deaths by April 30th. And I had a look at this, and at the time this was published, our rate of doubling was every 4 days. And I extrapolated that out till the end of April, and that worked out to be 6,000 deaths. So I thought, well, I'll come back and look at that in a couple of weeks and see what it looks like then. So I did it again last night. And the doubling time has since increased to then. increase to 6 to 7 days. And if you do that extrapolation to the end of the month, it gives an estimate that's very close to their estimate of a year ago. So their modeling was really good, much better than my simplistic one. And I just read a brief thing in the news today that they've done an updated model, which shows that I think it's going to be even better than this. So that's good news for us. Now that model was to the end of April. This one is to the end of the pandemic, which they estimate to be 18 to 24 months. So they're estimating 3,000 to 15,000 deaths in Ontario over those 18 to 24 months, which sounds pretty horrible. But if you put it in, it helps to put it in perspective with deaths from other causes. So we have 26,000 deaths every year from heart disease and strokes, or heart attacks and strokes mostly. So that's about 4 times as much as the 15,000 per 2 years. And also, some of these deaths will occur, some of the deaths in the coronavirus group will be the same people who would have died from cardiovascular disease anyway, because they'll be elderly and they'll have pre-existing conditions. So they'll die from one or the other, but they won't die twice. So it's not quite as ominous as it looks. This shows the percent of deaths by age in Quebec. And the pattern is similar in Ontario and New York. I've shown Quebec because it gives increments of every 10 years, whereas Ontario gives increments of every 20 years. So this is a more precise picture. But you can see that 90% of the deaths occur in people who are 70 and over, and 98% occur in people who are 60 and over. So for the younger people, they're going to get sick and they may have to go to the hospital, but they probably won't die. And I'm okay presenting this because I'm in the over 70 group. So I'm happy to be at the leading edge here. Now this was and I'd like to see what people think about this, this little news story that came out a week or so ago. This was a tweet from a member of Parliament. He said that most deaths are in care homes where average life expectancy is 2 years, and 65% usually die in the first year. Is it time to start moving Canada back to work? So the implication is that many of the people who are going to die are at the end of their life. They're going to die soon anyway. There's a cost economically and perhaps in terms in health to shutting down our economy. Should we be thinking if the cure is worse than the disease? And he got roundly criticized for this and retracted it. I can't help but thinking that somewhere in the back rooms, this type of discussion has been going on. I just would be interested to hear people's thoughts on this. And so this is my thoughts. I'm optimistic for the health aspects. I think things are looking good because we did act early and we've been behaving ourselves. I think our individual risk is low, unless you're in long-term care. And if you're in long-term care, you know, that's a really bad place to be if you want to live, if you want to escape this. Ottawa is a pretty good place to be. I think we're doing well here. I'm not so optimistic about the economic aspects. I think it's going to take a long time to recover, but I'm not an economist, so I haven't presented any data on that. I'm uncertain about both types of testing, the acute testing and the antibody tests. I hope they work out, but I just don't know enough about them yet. And I'm forever grateful for the people who are continuing to work to keep us all healthy and alive, actually. You know, the truck drivers, the grocery store people, the people who keep the water and electricity going in our telecommunications, who keep our society going, I think we owe them a big debt.